found in the lower pons. So in the lower pons, if you can remember our discussion of the brainstem, I said that the abducens nucleus is being surrounded by the fibers of the facial nerve. Are you clear? So these facial nerve fibers, they surround the nucleus of the abducens nerve to form a loop behind it. And so in the flow of the fourth ventricle behind the pons, it formed that facial colliculus. Axons from the nucleus of the abducens nerve, they pass out of these pons at the level of the ponto-medullary junction. You can remember that. So at that level of the ponto-medullary junction, as it comes out, there are three nerves along the ponto-medullary junction. Abducens nerve is the first from the midline, then followed by the facial nerve, then followed by the vestibulocochlear nerve. As this nerve emerges out of that junction, it comes in relation to one artery, what we call anterior inferior cerebellar artery, what we call AICA. Anterior inferior cerebellar artery. And so this artery, the facial nerve relates to this as it comes out, So as it comes out, the nerve comes forward within the posterior cranial fossa. As it approaches one very slopy area, what we call clivus, in the base of the skull within the posterior cranial fossa. This clivus, as it approaches the clivus, it passes forward, upward, and then turns laterally along the petrous bone. There is rocky-like swelling at the junction between the posterior cranial fossa and the middle cranial fossa there. That junction now, it is very, very rocky and rough, and that is why it is called petrous, looking like a rock. So that petrous portion of the temporal bone, because that area is part of the temporal bone. So it is like a conical shaped structure with the apex pointing towards the midline. So this nerve, as it approaches the clivus, which is a slopy surface of the anterior aspect of the posterior cranial fossa, so I said it passes forward and upward to slope over the clivus, and then it turns laterally over the apex of the petrous part of the temporal bone. As it comes to the edge of the apex of that bone, it is passing through a small canal. That canal is called canal of Dorello. And that canal is formed, number one, by the ligament taking origin from the anterior clinoid process, because there is one, there are about a pair of processes, facing the posterior cranial fossa. These processes, two on the lateral side, on the right side, two on the left side. This process is one above and one forward and one backward. So this anterior clinoid process, the ligament now passes from it down to the apex of the petrous temporal bone. So the nerve passes through that canal and then gets out of the canal and then passes through the cavernous sinus. So as it enters the cavernous sinus, if you can remember, we said there are multiple nerves that pass through the cavernous sinus, ranging from the oculomotor nerve, the trochlear nerve, the ophthalmic division of the trigeminal nerve, and what have you. So also, abducens nerve also passes through the cavernous sinus, and it lies in relation to the internal carotid artery. So this is internal carotid artery. So it lies at the level of the inferior lateral aspect of that artery. So it is a little bit below the artery and on its lateral side. So it gets out of the cavernous sinus, it goes into the superior orbital fissure, and from the inferior orbital fissure, it now enters into the orbit. As it enters into the orbit, it now goes to the area where it is going to swell. That is the lateral rectus muscle. Lateral rectus muscle is just a flat muscle like this. Just if you consider your hand to be the lateral rectus, and consider my head to be the eyeball, for example. So the lateral rectus is just attaching like this. So it has what we call the ocular surface facing the eyeball, and then you have orbital surface facing the orbit. Are you clear? So the nerve now supplies the lateral rectus through its own orbital surface. Are you clear? So once this nerve is being cut, at any site, you're going to have what you call abducens nerve lesion. Whether it is from the nucleus, whether it is along the nerve fiber, the lesion is the same. Are you clear? So here, you're going to have paralysis of the lateral rectus, and we all know the importance or function of the lateral rectus is to abduct the eye when you want to look, by the side like that. So unlike the opposite muscle that rotates the eye towards the midline, that is the medial rectus. So this one abducts the eyeballs laterally like that. So once you have lesion of that, muscle, the medial rectus will now take over, so that you have the eyes adducted towards the midline. That is what we call convergent squint. Are you clear? And then at the same time, if somebody wants to look by the side, the person is going to have double vision, so that you are going to see two images if you want to look laterally like that. That is when the lateral function of the lateral rectus, is not there. Then you are going to see things twice, double vision. That is what we call diplopia. So you have diplopia, and if the person is, having a fixed eyeballs, so he's going to have what we call convergent squint. And that is exactly what the patient is going to present to you. So, but this is just a summary of the abducens nerve. So I also have a break now before I now continue to discuss the next cranial nerve. That is the vestibulocochlear nerve.